Now we are beginning with the topic of uveitis. There are several questions asked from this topic in uveitis. Frequently this topic is being asked in university exams. Now talking about the questions what are asked, I mean there can be SQ question, there can be PBQ question also. Now taking in consideration of one PBQ question, here is how the question is presented to you. Right, the middle is man presented in IOPD with a history of pain and diminished vision in right eye for 2 days. It was associated with watering and intolerance to light. Right, and visual acuity in right eye is 6/36 with no improvement in pinhole. Ocular examination reveals lid swelling, circumcorneal congestion, small keratic precipitate in cornea, cells and flare in anterior chamber, and myosed pupil. Right, so what is the diagnosis? The diagnosis is our uveitis, or talking specifically it is anterior uveitis. Right, now here why we are saying it, because there is circumcorneal congestion, small keratic precipitate, cells and flare in anterior chamber are present. That's why. Now talking about other questions, what are the questions? So it is the questions, right? Define uveitis, its anatomical type, what are the cause of granulomatous uveitis, write down the difference between granulomatous and non-granulomatous uveitis. So these are the questions. And other questions, yes, other questions are also asked, such as outline the relevant investigation and treatment in the case of uveitis. Right, uveitis. So these are the questions. So we are going through each from defining uveitis. Now talking about definition of uveitis, we need to know initially about uveal tissue. What are uveal tissue? These are our iris, ciliary body, and choroid. Right, so uveitis, simply uveal tissues inflammation. Right, so the term uveitis strictly means inflammation of uveal tissues. Right, however there are adjacent structure close to uveal tissues such as retina, vitreous, sclera, and cornea. Due to close relationship between close relationship of anatomically distinct part of uveal tract, the inflammation process usually tend to involve the uvea as a whole. Right, it will spread to retina, vitreous, sclera, and cornea also. Now this was what uveitis. Right, you brief about uveitis is simply the inflammation of uveal tissues, which include this structure, our iris, ciliary body, and choroid. Along with this structure, the adjacent close related structure are also involved sometimes. Now talking about its classification, the anatomical classification is favorite. It is asked time and again. It was asked in 2020 also. Talking about anatomical classification, the first one is our anterior uveitis, intermediate uveitis, and posterior uveitis, and panuveitis. Right, as name suggests, anterior uveitis, that means it includes the anterior most uveal tissues like iris, that is iritis, iridocylitis, that means iris along with some part of ciliary body, that is pars plicatum, some part of pars plicatum. But anterior cylitis, what does this include? It includes pars plicatum of ciliary body. Right, the pars plicatum of ciliary body. Since we know the ciliary body is consisting of two parts, one is pars plana and pars plicatum. Right, pars plicatum is involved in our anterior uveitis. Talking about intermediate uveitis, here the pars plana of ciliary body is involved. Right, along with pars plana, peripheral part of retina is also involved. Right, and underlying choroid is also involved. Now talking about the posterior uveitis, we know the posterior most structure is our choroid. Right, it refers to inflammation of choroid, that is choroiditis. Almost always there is association of inflammation of retina, hence the term chorioretinitis is also used for posterior uveitis. Okay, and for intermediate uveitis, what was the term that was used? That was pars planitis, because it was involving pars plana of ciliary body, that's why it was called pars planitis. And for posterior uveitis, we use chorioretinitis, since choroid is involved and some periphery of our retina is also found here. And panuveitis, as the name suggests, pan, that means inflammation of whole uvea, that's our panuveitis. Now we are done with anatomical classification of uveitis. What is that? That is our anterior uveitis. In anterior uveitis, we talked about iritis, iridocylitis. Right, we talked about anterior cylitis, we talked about intermediate uveitis, posterior, and panuveitis. We are clear in these things. Now talking about granulomatous uveitis and non-granulomatous uveitis. Now talking about granulomatous uveitis, what is granulomatous uveitis? Right, it occurs because of infiltration of lymphocytes, plasma cells, right, and their mobilization. Now as there will be infiltration of lymphocyte, plasma cell, and their mobilization, what will happen is that there will be a proliferation of large mononuclear cells. Right, infiltration occurred, right, the mobilization took place, that will cause the proliferation of large mononuclear cells, now which eventually become what, epithelioid or giant cell, right? And these aggregate taking a form of nodules. These giant cell, epithelioid and giant cell, these aggregate in a form of nodules, right? And they are presented as iris nodules, right? And iris nodule and the nodules collection on cornea. Now iris nodules, now where are these nodules collected in iris? Near the pupillary border, right? If they are present near the pupillary border, then we call is Quepes nodule, right? Quepes nodule. And if are present near collarette or surface of iris, then we call it Basaka's nodule, right? And talking about nodule collection on cornea, right? Cornea, they are our what, keratic precipitate, right? And in severe condition, it is in granulomatous uveitis, there will be what, there will be this keratic precipitate will present as mutton fat keratin precipitate. So we are clear about what happens in granulomatous uveitis. In granulomatous uveitis, what will happen is that there will be infiltration of lymphocyte plasma cell, mobilization will take place, there will be what, proliferation of large mononuclear cells that will aggregate in formation of what, epithelioid and giant cell, right? And they eventually what, aggregate to form nodules, and these are collected in as iris nodules or in cornea. In iris at pupillary border, Quepes nodule; at collarette, Basaka's nodule; in keratic precipitate, mutton fat keratin precipitate is presented as this. So this is what happens in granulomatous uveitis, and often it is asked about the cause of granulomatous uveitis. They are tuberculosis, leprosy, syphilis, brucellosis, leptospirosis, viral, mycotic, protozoal and helminthic inflammations, right? Similarly, sarcoidosis and VKH, right? Forget, Korea, Nagi, Harada's disease. These are the cause of our what, granulomatous uveitis. Now talking about what, talking about another one, and that is non-granulomatous uveitis. Now talking about non-granulomatous uveitis, since there was what, formation of epithelioid and giant cell which aggregate to form nodules, and here these things will not happen. There will be marked dilation and increase in permeability of vessels, right? The vessels, retinal vessels, what will happen there? There will be dilation and marked increase in permeability of vessels that will cause breakdown of blood aqueous barrier, right? Now the fibrinous exudate and exudate and infiltration occurs by lymphocyte plasma cell and large macrophages, right? These lymphocyte plasma cell and large macrophages, what they will do is they will do outpouring of fibrinous exudate and they will cause infiltration. Now these are outpoured into what, our uveal tissues, anterior chamber, posterior chamber, and vitreous cavity. As a result, there will be what, circumciliary congestion. This congestion, circumciliary, how we are going to differentiate circumciliary congestion with the congestion of conjunctiva. Circumciliary congestion, what will happen is that these occur mainly deeper tissues, whereas the conjunctival congestion that occurs in superficial tissue. So these and another is these are mainly present on what, periphery, and they are present mainly on center. So that is also the difference. And there are cells, there are flare, keratic precipitate, meiosis will take place, iris nodules, synechia and hypopyon will be seen in this case. Right, now talking about cells, what are these? These are simply what, our WBCs, right? Lymphocytes in anterior chamber, right? And flare, these are proteins, right? Proteins in anterior chamber, as you can see in this diagram. Okay, let me show you. Okay, circumciliary congestion, right? Circumciliary congestion, what are these? These are what, these are the circumciliary congestion. They are mainly seen on the periphery, right? And they occur in slightly deeper plane than our conjunctival congestion, right? Conjunctival congestion, or they occur in superficial vessel, right? Talking about cells, yes, what are these? Cells, WBC, neutrophils floating in anterior chamber, right? WBC and neutrophils which are floating in anterior chamber, these are the cells. This is the earliest sign and hallmark of activity, right? And talking about flare, these are protein deposition in aqueous humor, right? Protein deposition in aqueous humor present in severe uveitis. Blood vessel get inflamed, because of which serum protein leak out and mix with aqueous humor, and the aqueous humor will become turbid and it will present as split. It will split the light, and that is what we see flare, right? How we see flare. So cells and flare, we are clear about it, right? WBC and neutrophils, which are floating in anterior chamber, right? These are what earliest sign, these are the flare, and our cells. And talking about flare, these are protein deposition in aqueous humor. That's it, right? In aqueous humor there is what? Protein deposition. Blood vessels get inflamed, serum protein leaks out, as we have already mentioned that there will be increase in permeability, right, and dilation of vessels, and this will mix with aqueous humor, and the aqueous humor will be turbid. It will split the light, like and that is what our flare is, right? In dark room, if we if we turn on torch, then how we see that beam of light, and it is seen in such a way, flare is seen in such a way, right? These were this and another, yes, as you can, as I have already said, right, it is presented in such a way. Creatine precipitate, we talked about this creatine precipitate, right? They are present in cornea. And yes, you can see ALRTs. What are these ALRTs? This is triangular area in inferior part of what? Our cornea, where creatine precipitate get preferentially stuck, right? These are ARLT, right? Okay. And yes, mutton fat, it was what? Characteristics of granulomatous uveitis, right? Iris nodules, copious nodules on the present on the papillary margin, vesicous nodule present on surface of iris, seen in granulomatous diseases, right? Okay, now moving further. Okay, these are what? These are the characteristics, right? These are the sign, the symptoms. Okay, talking about the difference between granulomatous and non-granulomatous uveitis, right? Onset, the granulomatous, it is insidious, slowly progressive, whereas non-granulomatous, it is acute, right? Pain, there is pain is marked in non-granulomatous. Photophobia is marked in non-granulomatous. Ciliary congestion is marked in what? Our non-granulomatous. Creatine precipitate, right? These are small in non-granulomatous, but mutton fat, creatine precipitate, we already said, right? In cornea, they are present in what? Our this granulomatous. Aqueous flare, right? Aqueous flare are mild but marked in non-granulomatous. We said the aqueous flare, how they are presented. They are what is the reason that they are presented? They are presented because there is what? Permeability, increased permeability, that will cause what? The mixing of aqueous blood protein with aqueous humor, right? Because of protein mixing with aqueous humor, there will be turbidity of aqueous humor, and that will cause what? That will cause the splitting of light, and that is what our flare is. Iris nodules, right? We already said these are usually present in granulomatous and absent here. And iris nodules, we talked about. What are the iris nodules? These are vesicous nodule and our what? Copious nodule, right? And posterior synechia, it is thick and broad based but thin and tenuous in non-granulomatous. Fundus, it is nodular lesion and it is diffuse involvement in non-granulomatous, right? So these are the difference between our granulomatous and non-granulomatous uveitis. Now talking about what? The investigations, right? Talking about the investigation, now what are the essential investigation that we need to do, or if there will be the management of uveitis, what we are going to do. Now talking about the management, let's begin with investigation, right? Now before ordering investigation, a thorough ocular systemic examination is required, right? Ocular systemic examination is required, which may provide clue of underlying disease, right? Now for this ocular systemic examination, what are the things that should be included in ocular systemic examination, such as we will go through what? Examination of visual acuity, right? We'll go through the examination of lids, conjunctiva, cornea. We'll do slit lamp examination. We'll look up about the irrigation of lacrimal sacs. We'll perform all that things. Investigation include a battery of tests because of varied etiology. However, an experimental ophthalmologist soon launched to order a few investigation of considerable value, which will differ in individual case depending upon the information gained through clinical work. A few common investigation required are listed here. Like what we'll do. Okay, there are several causes of uveitis. We have already mentioned about the several cause, right? Several cause of uveitis. So we need to find the exact cause. Now to find the exact cause, we need to give investigation of several things, like total leukocyte count, differential leukocyte count, right? It will have a general information about inflammatory response of the body. We're talking about hematological investigations. So talking what are the investigation that we send? We send hematological investigation, we send urine examination, stool examination, right? Similarly, radiological investigation and skin test. Now these have got their own significance. Like hematological investigation, what we send, right? In hematological investigation, we send for total leukocyte count, differential leukocyte count, that will tell us about the inflammatory process going on in a body. Talking about ESR, right? ESR is also essential to ascertain existence of any chronic inflammation condition in the body. ESR. Similarly, blood sugar level to rule out diabetes mellitus, right? Blood sugar level to rule out diabetes mellitus. Similarly, blood uric acid in patients suspected of having gout. Serological test can be done for syphilis, toxoplasmosis, and histoplasmosis. Similarly, test for anti-nuclear antibody, right? RS factor, right? LE cells, C-reactive protein, anti-streptolysin O, EC for sarcoidosis. So what are the hematological investigation we are sending? The hematological investigation that we are sending is, we are sending what? DLC, right? DLC, TLC. We are sending what? We are sending ESR. We are sending ESR, blood sugar, blood uric acid level. We are sending serological test, right, for syphilis, toxoplasmosis, and we are testing for what? For anti-nuclear antibodies also, RS factor, LE cells, C-reactive protein, anti-streptolysin O test, right? Okay. Now these were for what? These were hematological examination. Talking about urine examination, we do it for WBC, post cell, and RBCs, right? Culture to rule out urinary tract infection, UTI, right? To rule out UTI. And stool examination, we do it for cyst and ova to rule out parasitic infestation. There can be parasitic infestation also. And radiological investigation include what? It include X-ray of chest, paranasal sinuses, sacroiliac joint, and lumbar spine, right? CT scan is also used for CT scan of thorax, right? For in the case of suspected sarcoidosis, right? And MRI can be done of head for suspected sarcoidosis, demyelination, and lymphomas. Such as skin test can be done. That includes tuberculin test, right? And KVM's test for sarcoidosis, toxoplasmin test, lapromin test, and pathologic test for Behçet's disease, right? Okay, now what are the different investigations we talked about? The different investigation that we talked about is, we talked about what? We talked about our what? Hematological. And then we talked about what? We talked about blood, urine, right? Blood, uric acid. We talked about urine examination, right? We talked about stool examination, right? We talked about skin test, right? Hematological, we talked about what? Several, right? Several hematological examination, like TLC, DLC. We talked about serology, right? We talked about serology, right? We talked about what? Blood sugar, right? We talked about we talked about blood sugar, blood uric acid, right? Blood sugar, blood uric acid. We talked about anti-nuclear antibodies test. In in urine, we did it to rule out UTI. In what? In stool, we did it to rule out parasitic infestation. Similarly, in skin, we did it for tuberculin test, right? Toxoplasmin test. These are the things. So these were the relevant investigations sent, right? Relevant investigations sent. As you can see, what is this? What are these? These are keratin precipitate. We talked about ARLT line, ARLT triangle, right? These are what? These are keratic precipitate, right? As you can see, now here we can see what is this? Aqueous flare, right? Protein deposition within aqueous humor, causing it turbid in appearance, right? You can see it is looking like in dark room we are turning on torch, right? Similarly, what is this? This is hypopyon. It is also seen in the case of what? Non-granulomatous uveitis, right? Now what is this? Here you can see iris nodules on the periphery. We can see iris nodules, sorry, okay, we can see right here the iris nodules, right? Iris nodules. And we can see synechia, right? Annular total posterior synechia can be seen right here, as you can see, right? Total posterior synechia can be seen right here. Similarly, what we can see here is festooned pupil, right? Because of posterior synechia, right? Posterior synechia, there is festooned pupil, and it is seen under dilated pupil, and it is the complicated cataract, as you can see. So these are what? These are the investigation signs, symptoms of our uveitis. Now talking about the treatment modalities. Now what are the treatment modalities? Talking about the treatment modalities, what are the treatment? One, one is non-specific treatment, specific treatment, and treatment of complication, right? One is what? Non-specific treatment. Now talking about non-specific treatment, right? Non-specific treatment, there what we do in non-specific treatment is we provide what? Local therapy, right? We provide systemic therapy and physical measures. Local therapy, systemic therapy, and physical measures, right? And talking about this local therapy, what we do is we provide cycloplegic drugs, corticosteroid, antibiotics. In systemic therapy, we provide corticosteroid and NSAIDs. So we're talking about what? Non-specific treatment, right? In local therapy, we provide what? Cycloplegic, corticosteroid, and antibiotics. Similarly, in systemic therapy, we provide corticosteroid and NSAID. And we also give what? Physical measures, right? Physical measures. Now talking about specific treatment of cause and treatment of complication, it will come sooner. Now yes, in non-specific treatment, we already said about local therapy, where we are going to give what? Cycloplegic, and the important cycloplegic is 1% hydrogen sulfate. If the person is allergic to it, we can use we can use 2% hometropine, right? Now what will this cycloplegic drug do? What it will do is it gives comfort to eye, right? It gives comfort to eye. How it gives comfort to eye? By relieving spasm of iris sphincter and ciliary muscle. What it will do is it will prevent the formation of synechia and may break already formed synechia also. It reduces exudation by decreasing hyperemia and vascular permeability, right? And it also increase blood supply to anterior uvea. And this is how this atropine is working here. What it is doing, it is relieving pain by by preventing ciliary spasm, right? And it is causing increase in blood supply to what? Anterior uvea. It is reducing exudation, right? Vascular permeability, right? It is preventing formation of synechia, right? And it will break the already formed synechia also. Now in local therapy, what we can do is we can give corticosteroid. Now corticosteroid are effective in the case of iridocyclitis, and the corticosteroid that we give more often is dexamethasone, betamethasone, and hydrocortisone, along with prednisolone also. The mode of action is it reduces inflammation by their anti-inflammatory effect, right? Anti-allergic, right? Anti-inflammatory, anti-allergic, and anti-fibrotic activities, right? Anti-fibrotic activities. So that is how the corticosteroid will relieve this condition. Now another thing is we can do is we can give broad spectrum antibiotics also, right? Broad spectrum antibiotics also. Now these are the local therapy. We already said cycloplegic drug, right? We talked about its mechanism of action. We talked about corticosteroids, their mechanism of action. We talked about broad spectrum antibiotics also. Now going into specific treatment of cause. Now specific systemic therapy and physical measures. Now we forgot to mention about physical measures. Now talking about the physical measures, what we can do is we can do hot fermentation and dark goggles, right? Now it is soothing and diminished pain increases. It is very soothing and it diminishes pain and increases circulation, and thus reduces venous stasis, right? As a result, more antibodies are brought and toxin are drained. Hot fermentation can be done by dry heat or wet heat, right? Similarly, dark goggles, since there is photophobia, right? Since there is feeling of discomfort in bright light, so what we can do is we can use we can use dark goggles, right, in sunlights, that will reduce photophobia, lacrimation, and blepharospasm, right? Now these are our physical measures. Now talking about treatment of specific cause. Treatment of specific cause, there are several causes we have already mentioned, right? There are several causes for it. For treatment of specific cause, right? For treatment of specific cause, what we can do is the full course of if it is the tubercular cause, then what we can do is full course of antitubercular drug can be given. Underlying cause disease, right? Adequate treatment of syphilis, toxoplasmosis can be given. So depending on the cause, either it is granulomatous type or non-granulomatous type. Now talking about specifically about granulomatous type, which type, what is the cause. By knowing that, we can provide a specific treatment. Now treatment of complication, right? Now there are several complications, right, such as glaucoma, secondary glaucoma, right, post-inflammatory glaucoma, complicated cataract. Now these can be treated, right, these can be treated, right, as the inflammatory glaucoma, it can be treated by lowering the intraocular pressure, by providing timolol, right, providing acetazolamide, right, and these are latanoprost can be given. Pilocarpine and latanoprost eye drop are contraindicated in inflammatory glaucoma, right, inflammatory glaucoma. And post-inflammatory glaucoma, right, due to ring synechia, is treated by laser iridotomy, right. Surgical iridotomy may be done when laser is not available. However, surgery should be performed in quiet eye under high dose of corticosteroid. Simply complicated cataract, right. Here what we do is we do lens extraction with guarded prognosis in spite of all precaution, right. Presence of fresh keratin precipitate is considered a contraindicated intraocular surgery. So if there is keratin precipitate, we just prevent it. And retinal detachment, right, it will require vitrectomy and management of complicated retinal detachment with poor visibility prognosis. Phthisis bulbi, especially when painful, require removal by enucleation operation. So these are the treatment of complication, right, several complications. So we mentioned about inflammatory glaucoma, what we can give timolol, right. Inflammatory glaucoma, what we can give timolol and acetazolamide, right. Pilocarpine and latanoprost drop are contraindicated, right. Pilocarpine and latanoprost are contraindicated. Similar post-inflammatory glaucoma, what we can do is here we need to do iridotomy, right. Laser iridotomy, if it's surgical iridotomy may be required if laser is not available, right. So complicated cataract, in complicated cataract what we do is we do lens extraction, contraindicated if there is presence of fresh keratin precipitate, right. Retinal detachment, what we will do in retinal detachment, if it is exudative type, settles itself if treated aggressively, right. If it is tractional type, vitrectomy and management of complicated retinal detachment can be done, right. Okay, now if it is phthisis bulbi, right, phthisis bulbi, especially when painful, require removal by enucleation operation. So we talked about the different management, right, what are the investigations should be done, how the treatment is done. We talked about that thing. Now last but not the least, what we can do is we can talk about the complication of uveitis. Talking about the complication of uveitis, we already mentioned some of the complication. We're talking about treatment of complication. So similarly, so the complication is, the first one is, what is the first one? The first one is our complicated cataract, right. Complicated cataract. Now complicated cataract, right, it is the complication of persistent iridocyclitis, right. Iridocyclitis, we know it is what anterior uveitis, right. In presence of posterior synechia, complicated cataract progresses rapidly to maturity, right. This is the one complication, and another is secondary glaucoma, right. Secondary glaucoma, there are talking about secondary glaucoma, there is one early glaucoma and another is late glaucoma. Now early glaucoma, it occurs during active disease, right, active phase of disease, presence of exudate anti-inflammatory cell in anterior chamber. What they will do is they will do clogging of tubercular meshwork, right, and this will cause decrease in drainage and it will cause increase in IOP. So we know that in anterior chamber there are cells, right, cells and flares. Now these cells and flare, what they do is they block the angle, right, they block the angle trabecular meshwork, because of which there will be less drainage and there will be increase in intraocular pressure, and that will cause our glaucoma. And late glaucoma, what will happen in late glaucoma is there is ring synechia, right, that will cause sacculosio pupillae, and also there is organized exudates, right. One is ring synechia and another is organized exudate, right. Now this ring synechia, what it will do is it will form sacculosio pupillae, right, and what it will do is it will form oculosio papillae, right. Now what they will do is they will together block pupil, right, they will cause pupillary blockage. Now since there will be pupillary blockage, blocking of aqueous flow from posterior to anterior chamber is blocked, that will cause increase in IOP, right. And other complications are our cylitis membrane, right. Similarly choroiditis, right, retinal complication are also there. Papillitis, band shaped keratopathy, pithis bulbi are also there. So these are the several complication of our our uveitis. As I mentioned, what are the several complication of uveitis? One is our complicated cataract, right? Complicated cataract. Another is secondary glaucoma. Similarly, cylitis membrane, right? Choroiditis, retinal complication, right? Similarly, papillitis, phthisis bulbi are also there. So these are the complication of uveitis. So this was all about uveitis with it. Okay, and let's see these questions. What is your professional diagnosis? That is our anterior uveitis or uveitis. Enumerate the three causes of sudden and painful diminution of vision. So sudden and painful diminution of vision, it can be what? It can be our one is our this anterior uveitis. Another is, we can say, acute conjunctivitis. We can say acute primary angle glaucoma, right? It can be also said acute congestive glaucoma, or we can say that. How will you manage this case? We already talked about management of this case. Enumerate two important complication of this case. We talked about, yes, complication of this case also, right? We talked about that things. So this was all about the uveitis.